All right, I think in the interest of time, we're going to go ahead and get started. And again, let me welcome you all. This is Mitchell Warren from AVAC, and we are delighted to welcome you here on behalf of all of us at AVAC, as well as a remarkable partnership that we've had for many years with ICW East Africa, who've really been a leading voice, not just in Africa, but globally, on the issue related to hormonal contraceptives and HIV. For many of you on the line, you will know this is not the first call we've had on this topic, and if you do go on our website, if you haven't already, at avac.org, and we'll see that under work that we do in partnership with a number of people on the line, the area of understanding hormonal contraceptive and risks has been quite an active area of conversation over the last several years. And if you look at that website, avac.org, and then look at hormonal contraceptives, you'll find that there have been a series of calls, and we're delighted that this one really, I hope, will allow us to connect a number of dots that have emerged over the last several years. Some of you will have been on our call just about 5 or 6 weeks ago in March, shortly after the World Health Organization issued updated recommendations related to hormonal contraceptives and HIV, particularly related to injectable contraceptives. And we did a call shortly after that to understand the processes that were at play, and we are especially delighted today to have James Kiarie from the World Health Organization, who's been one of the leaders there in the process of reviewing evidence and developing updated recommendations. I should say, just in terms of logistics for today, we are in a global mute for this call because we have many people from all over the world on, which is very exciting, but we definitely want to hear from you all. So the plan will be for James to present an update in just a moment. If you have questions throughout his presentation, feel free to post them. If you're on the ReadyTalk interface online, you can post them in the chat function there, or you can email them at any point to avac@avac.org, and we'll moderate discussions after James presents, and we'll also hopefully have time to open the line, and I'll give you instructions on how to unmute yourself for that. We will be posting a recording of this call and the slides shortly after completing this call today. So just wanted to give you all a sense of that, and thank you again for making the time for what really has been, over the last 6 or 7 years, a critical issue that involves really important science. It involves leadership from the World Health Organization as the normative agency, really leading on helping us all, particularly the local governments, understand the implications of these, and particularly also giving voice to civil society and advocates who've been tracking this issue for such a very long time. So we're delighted to bring all those pieces together, and without further ado, I will turn it over to James Kiarie, who is at the World Health Organization in Geneva, to take us through the updated WHO recommendations.
Thank you very much, Mitchell and your colleagues. I'm actually very delighted, and for all of you online, I'm very delighted at this opportunity to present on the guidance on hormonal contraceptive eligibility for women at high risk of HIV. And this is a recent update of WHO guidance. I also really appreciate Emily, who I think has not been able to join the call today, for all the work that she has had to do to make this particular call possible. So before I begin, I would also like to thank members of the Guideline Development Group and the external peer reviews whose input shaped the guidance statement on hormonal contraceptive eligibility for women at high risk of HIV infection. I would also very much like to thank Dr. Mary Lynn Garfield. Dr. Mary Lynn Garfield is working with us here in WHO and has been leading the process of development of the medical eligibility criteria for about the last 10 years. And she was actually the one who led the process of updating this guidance from WHO. So on the next slide, for more than 20 years, WHO's Department of Reproductive Health and Research has produced the medical eligibility criteria for contraceptive use, which is popularly known as the MEC. On 1st June 2015, WHO issued the 5th edition of the MEC. The MEC is an evidence-based guideline that provides more than 2,000 recommendations on the safety of 25 contraceptive methods for women with certain medical conditions or personal characteristics. In particular, it includes recommendations on contraceptive eligibility for women at high risk of HIV infection. Moving on to the next slide, on slide 3, although some of you may already be familiar with the format of the MEC recommendation, I would like to take a moment to briefly review the meaning of the 4-category scale that is used to indicate eligibility. Category 1 indicates a medical condition or characteristic for which there are no restrictions on the use of the method. Conditions classified as Category 2 indicates that the method can generally be used, but careful follow-up may be required. Category 3 conditions are those that require careful clinical judgment and access to clinical services. And Category 4 conditions are those that present an unacceptable health risk and the method in question should not be used. In settings where resources for clinical judgment are limited, the 4-category scale can be simplified into 2 categories. Thus, women with a condition classified as Category 1 or 2 can use the contraceptive method, whereas if she has a Category 3 or 4 condition, she shouldn't use the method. Moving on to the next slide. Within the 5th edition of the MEC, there are no restrictions on the use of combined hormonal contraceptive methods, that is the pills, the patch, and the vaginal ring, or for progestin-only contraceptives, such as pills, injectables, and implants, for women at high risk of HIV. Women at high risk of HIV can also generally use the LNG-releasing IUD, for progesterone-only injectables, and this includes DMPA administered intramuscularly or subcutaneously, or NETEN. The Category 1 recommendation in the 5th edition of the MEC was accompanied with a clarification. And the clarification indicated that women at high risk of HIV who are using progestogen-only injectables should be informed that available studies on the association between progestogen-only injectable contraception and HIV acquisition have important methodological limitations, hindering interpretation. The public health impact of any such association would depend upon the local context, including the rates of injectable contraceptive use, maternal mortality, and HIV prevalence. This must be considered when adapting guidelines to local contexts. Given the importance of this issue, women at high risk of HIV infection should be informed that progestogen-only injectables may or may not increase their risk of HIV acquisition. Women and couples at high risk of HIV acquisition considering progestogen-only injectables should also be informed about and have access to HIV preventive measures, including male and female condoms. So for the rest of this presentation, I will focus on the methods presented in this table, with the exception of the LNG IUD, which was not addressed in the recent WHO expert consultation. So next slide. Following the release of the 5th edition of the MEC in 2015, WHO became aware of new data published since 2014. Consequently, WHO commissioned an update of the systematic review that summarized the evidence supporting the 5th edition's recommendations. This systematic review, which offers a synthesis of the body of evidence on hormonal contraception and HIV acquisition in women, was published as open access in the journal AIDS on 9th August 2016. And to just summarize briefly, the review identified 10 new studies, of which 5 were considered informative but with important methodological limitations. The review concluded an important next step would be for WHO to determine whether it should consider its global guidance on DMPA and NET for women at high risk of HIV infection. Accompanying the publication of the review, WHO issued a statement announcing that an expert review group would convene later in 2016 to examine the links between the use of various hormonal contraceptive methods and women's risk of HIV acquisition. On slide 6, during 1st to 2nd December 2016, WHO convened a meeting of the Guideline Development Group to review new evidence on the risk of HIV acquisition with hormonal contraception and, where appropriate, revise specific recommendations issued in the MEC 5th edition. The review process followed the standards requirements specified in the WHO Handbook for Guideline Development. Additionally, to provide additional context for the discussion, the following topics were presented: results from a decision analysis modeling competing risks of unintended pregnancy, maternal mortality, and HIV acquisition risk. Results of a brief survey of program interpretation of WHO recommendations on contraceptive eligibility for women at high risk of HIV. Further, a panel discussion was organized to understand the perspectives of program managers and directors on the topic. There was also a summary of the systematic review findings and a review of biological plausibility and potential mechanisms linking hormonal contraception and HIV acquisition. Following these presentations to the Guideline Development Group, the Guideline Development Group considered the following factors in making their determination. One, they considered the quality of the evidence, values and preferences of users and providers, a balance of benefits and harms of contraceptive use, contraceptive choice, equity and human rights, acceptability and feasibility. Slide 7. For combined hormonal contraceptive methods, this refers to pills, the patch, the vaginal ring, and the combined injectable contraceptives. The Guideline Development Group considered evidence from 11 cohort studies deemed informative but with important limitations. This represents data from more than 43,000 women. As presented in this grade table, no studies on the use of combined contraceptive patch, the ring, or injectable were identified. 10 of these studies found no statistically significant association between their use and HIV infection, while one study reported a marginally increased risk, and the overall quality was rated as low to moderate. The adjusted hazard ratios reported among these studies ranged from 0.66 to 1.8. And none of the studies reported a statistically significant increased risk of HIV acquisition among women using combined hormonal contraceptives compared with women not using hormonal contraception. Slide 8. Therefore, the GDG determines that the current MEC recommendations for combined hormonal contraceptive methods among women at high risk of HIV should be upheld. And these methods remain as Category 1, indicating no restriction in their use. And now we will discuss the progestin-only contraceptives, which is what is presented in slide 9. And I'll move on to the next slide, which is slide 10. And this is looking at for progesterone-only implants. So for progesterone-only implants, 2 small studies assessing levonorgestrel implants were considered to be informative, but with important limitations, which did not suggest an elevated risk, although the risk estimates were imprecise. One study reported no association between the use of progestogen-only pills and HIV risk. The adjusted hazard ratio for these 2 studies ranged from 0.96 to 1.6, and the confidence intervals around these estimates included the null value. The next slide, for progestogen-only injectables, and this refers to DMPA-IM, DMPA subcutaneous, and NET-10. Evidence from 13 observational studies on DMPA and NET-10 or non-specified progestin-only injectable were reviewed, as they were considered to be informative but with important limitations. Together, the data for these studies continues to show some association between use of progestogen-only injectables and risk of HIV, but it remains unclear whether this results from a causal relationship or from methodological limitations. I would like to draw your attention to the blue arrow on the right side of the slide. It points to the adjusted hazard ratio pulled from the 9 studies examining HIV acquisition risk among women using DMPA versus women that were not using a hormonal contraceptive. We see the adjusted estimate is 1.4 with confidence interval ranging from 1.23 to 1.59. The I-square value indicates low heterogeneity across the studies summarized. You'll also see on the next row that when women using NET-10 are compared with women who did not use a hormonal contraceptive method, the pooled estimate risk of HIV acquisition was 1.15, and the hazard ratio is included, one suggesting a lack of statistical significance. Lastly, a head-to-head comparison between HIV acquisition risk among DMPA and NET-10 users, this is in the last row, identified an adjusted hazard ratio ranging from 1.32 to 1.41 with 95% confidence intervals for each of these estimates reaching statistical significance. Next slide. Additionally, a systematic review of the literature was performed for studies, qualitative or quantitative, on contraceptive users and providers' values and preferences, views and concerns regarding the contraceptive methods considered under the MEC guidelines. Any studies published between January 2005 and October 2016 in any language were searched for in 10 databases. A total of 206 studies were identified that met inclusion criteria. No studies were identified that focused specifically on the issue of potential increased risk of HIV acquisition associated with specific hormonal contraceptive methods. However, key themes in women preferences were identified. Across the studies, women's values and preferences centered on themes of available options for contraception, ease of use, side effect profile, and contraceptive efficacy. Contextual factors such as contraceptive method available, counseling and opinions of social networks also influence decision making. The next slide looks at the recommendations for progestin-only. The next slide looks at the recommendations that were made for progestogen-only contraceptives. So as you can see, after discussion in the guideline development group, it was concluded that the use of progestogen-only contraceptives, injectables, should be a category 2 for women at high risk of HIV infection. And the clarification was that there continues to be evidence of a possible increased risk of acquiring HIV among progestogen-only injectable users. Uncertainty exists about whether this is due to a methodological issue with the evidence or real biological effects. In many settings, unintended pregnancies and/or pregnancy-related morbidity and mortality are common, and progestogen-only injectables are among the few types of methods widely available. Women should not be denied the use of progestogen-only injectables because of concerns about the possible increased risk. Women considering progestogen-only injectables should be advised about this possible increased risk, about the uncertainty, on whether there is causal association, and how to minimize their risk of HIV, acquiring HIV. So this was the change that was recommended by the Guideline Development Committee. And therefore, in conclusion, for women at high risk of HIV, WHO recommends no restriction for combined hormonal contraceptives, progestogen-only pills, or progestogen-only implants. For women at high risk of HIV infection, they can use DMPA, both IM and subcutaneous, and NET-10. DMPA, both DMPA IM and DMPA subcutaneous and NET-10 injectables are now MEC category 2. And this decision was guided by the importance of optimizing the rights of women and girls for contraceptive choice and informed decision making, and also the importance of clearer communication of the imperative for fully informed counseling. And it was felt that earlier recommendations had not led to this intended goal. So what are the implications for these recommendations for program providers, for programs, policies, and for providers? So programs can continue to offer all methods of contraception to women at high risk of HIV infection. And WHO resources are available to complement and support these recommendations. Comprehensive contraceptive and HIV information and counseling services must be available equally to everyone. Contraceptive counseling is a core component for supporting informed choice and decision making. Integration of high-quality family planning and HIV services is an essential strategy to optimize reproductive health for all individuals. And national programs are urged to expand upon the range of available family planning, contraceptive methods, and options. And just to emphasize that, as in the past, WHO places high priority on routinely reviewing its recommendations and is committed to continually review the body of evidence that provides the foundations for these recommendations. Further, WHO strongly supports the need for further research to identify definitive answers that address concerns around increased biological vulnerability for HIV among women using progestogen-only injectable. I would like to turn on, after having presented the guidance statement, maybe just to update all the participants on what has happened since this was issued. And when this statement was about to be issued, having learned from previous challenges in communication, WHO did hold a pre-launch webinar with a lot of the stakeholders that would be called upon and asked questions regarding the implementation of these guidelines. We also have a list of frequently asked questions and their answers, and this can be found at our RHR website, and also a web story that gives a simplified version of the guidance. We did do several press briefings at around the time of the launch, and subsequently we've had some follow-up with countries regarding implementation of these guidelines. Specifically on 10th to 13th of this month, we held a stakeholders meeting on hormonal contraception and HIV in Johannesburg, and I'll talk briefly a bit about that meeting. And recently, about a week ago, we did hold a webinar for implementing partners to discuss this guidance and also to hear from the partners what they have done as a follow-up of this guidance. So the next slide. I just want to highlight here some of the stakeholders' reactions in terms of from what has happened. What are some of the things that we have seen happen following issuing of this statement? A lot of the partners, including EVAC and other organizations, have done a lot of very good work disseminating the guidance so that there is more knowledge and awareness of this revised guidance to regional, national, and even to subnational implementers. In terms of research, there were many ongoing studies that were looking at various questions around progestogen-only injectables and HIV, or progestogen-only injectables and other issues. And many of these studies have revised their informed consent, and or the information sheets have been revised for participants. In terms of guidance, there are derivative technical briefs that have been developed by some partners, and those who are delivering services. Some of them have developed medical and service delivery guidelines that respond to this guidance. In terms of service delivery, some partners have developed messages, and we know particularly messages that can target low literacy, most vulnerable and marginalized populations. Information, education, and counseling materials have also been developed, including cue cards and other training, counseling, and mentorship tools. There are also partners who are thinking, this has not really happened, but they are thinking of developing some tools that can be useful for HIV risk assessment by providers, and also counseling tools that will better explain the possible increased risk in HIV risk. Several countries are already in the process of integrating the new guidance into their national guidance. So next slide. So this is just an update on the meeting that I referred to that was in Johannesburg. This was a 3-day meeting, was in 2 parts. One was more of a research meeting, the first part, and the second part was really looking at national implementation of this guidance. So it had many participants who were drawn from WHO, from ministries of health, and were drawn from 12 of the 14 African countries with HIV prevalence above 5%. And we also had the ECO Consortium members who are attending. We had several donors who were present. We had representatives of civil society and advocates who were also present in the meeting. And just to highlight some of the three outcomes from that meeting, the report for the meeting is still under preparation. So this is just my reading from discussing with those who are at the meeting. One was that clearly the new guidance has been widely disseminated, and we appreciated that among the participants there has been really a good effort to disseminate, so that among particularly program managers and policymakers, there is a high level of awareness. However, it was said that in terms of dissemination, there is need for extra effort to get this message to the providers and eventually get it to the users. Another important outcome was the importance of continuing research in this area. And what was emphasized, particularly from the research meeting, was the importance of stronger collaboration between the scientists who are doing basic sciences, epidemiologic scientists, and also the health system researchers. The countries, most of the countries present, are planning to host stakeholders consultations to ensure that the guidance actually gets implemented. So what are some of the next steps? This is on the next slide. What are some of the next steps for us from WHO? So we are going to continue support for the in-country consultations, and we are responding to questions. We are using the WHO in-country offices to support the processes, and other experts who are available in-country, and ensuring that as broad a stakeholder involvement as possible. We are also monitoring the implementation to see that the guidelines does actually happen. There is a change in the communication, and that the users are given appropriate counseling. We are also planning to share some of the lessons and document our experiences from this process. We will continue with the dissemination. A lot of the people who we have consulted with have told us that one-off effort is not likely to be effective. So we thank EVAC and others for continuing to hold these webinars repeatedly, because I think it has to be a continuing effort. We cannot expect that once it's done once, that will be the end. And for this, we are holding a webinar on the first week of May. Actually, it will be on 5th of May, and this is for the Francophone countries. We are updating the global handbook for providers so that it contains specific job aids that can be used for counseling users with respect to this new guidance. We are also welcoming collaboration with partners who are supporting implementation of this guidance, and I would just like to highlight one of the partners, which is the Health Communication and Capacity Building Initiative based in Johns Hopkins. And prior to even issuing of this guidance, they had developed a strategic communication framework for hormonal contraceptive methods and potential HIV-related risks. So we are closely working with them to ensure that countries and users can also benefit from their expertise, and also from some of the work that has already gone into development of this communication framework. So I would like to stop there and and hand over back to Michelle Warren. And you can follow us at Twitter for our department. And for more information, you can also visit our website. Again, thank you very much for inviting me, and looking forward to further discussion. Over to you, Michelle.
Great, James. Thank you so much. That was remarkably thorough and super informative, and lots of different questions coming in. Let me just again thank you, and then talk about the logistics for the rest of the next 25 minutes or so. We certainly are really happy to have so many on the line, and would love to hear your voices as well. And in a moment, I'll open it up to have people unmute your line by pressing *7. Introduce yourself, ask question briefly, and then hit *6 to remute so we keep the line clear for recording. And again, you can continue to put your questions in the chat feature or via email at avac@avac.org. But James, that was incredibly helpful, and a couple of questions had come in as you were going, asking about the implementation and communication meeting, and you covered that very well. But two additional questions had come in, and I wondered if you might be able to address them before we open up the line. One, and you described the process and the decisions and discussions related to injectable contraceptives, both DMPA, Depo-Provera, and NET-N. And there were some questions about the differential information that's available, and perhaps if you could give a little bit of perspective on what we know about each of those methods independently of the other, and what happens next in terms of grouping them together. And then just the second one that had come in from someone, also someone from South Africa, asking, what about Cyanopress, which is, and you can describe better than I, a different approach to an injectable, which is now being widely studied in a number of settings, and how the recommendations you've just described might or might not impact Cyanopress. So I wonder if you could take those two different kind of product-related questions, and then perhaps we'll open it up for additional questions. So, James?
Very much. Sorry, I muted myself.
No problem. I had a feeling. Go ahead.
Yes. So thank you very much. I think this is actually a question that we will soon be adding on our frequently asked question. And this question is, why do we, I think it is about, for this guidance, DMPA, NET-N, DMPA-IM, DMPA subcutaneous, which is Cyanopress, and NET-N are classified as one. And I will just go back to some of the discussions that as they occurred in the expert consultation. One is that we have no data on DMPA subcutaneous. There's completely no data in terms of risk of HIV acquisition associated with subcutaneous DMPA or Cyanopress. However, there is some limited data in terms of the pharmacokinetic and the drug levels that are achieved in the blood following use of DMPA subcutaneous and DMPA-IM. And the main take-home messages from this is that the drug levels in the blood following these two drugs, although the dosage is different, one is 150 milligrams, the IM, the subcutaneous is 104. But the steady blood levels achieved are equivalent, they are the same. There's no difference in terms of the blood levels. However, DMPA-IM does tend to have a peak of very high levels of drug immediately after the IM injection that then settles to the same level as we have the subcutaneous injection. So the only difference in terms of the drug in circulation is that one has this peak and then the steady levels are the same. There's no evidence that the increased risk of the possible increased risk of HIV acquisition is associated with that peak of DMPA-IM, or whether it is due to the constant circulating levels. So we do not have any evidence to really say that this question, that the DMPA subcutaneous will be any different from DMPA IM in terms of HIV acquisition risk. And I think the counseling for women when they choose subcutaneous and IM should be the same. For now, we are not having any difference. If you look at the studies around DMPA IM compared with those around NET10, if you look at the specific hazard ratios that the studies obtain, the hazard ratios are very similar. However, the studies on NET10 are not statistically significant, while those on DMPA IM have tended to be statistically significant. There was a lot of discussion whether this shows that there should be less concern for NET10 as compared with DMPA IM. Also, some of the biological mechanism studies have suggested that, of course, we know that the compound is different between the two injectables. However, in terms of the impact of these injectables on biological variables that may affect HIV infection risk, the results have been very variable. And therefore, after a lot of discussion, it was decided that at the current time, we really do not have a reason to say that the results for NET10 are reassuring as compared to those for DMPA IM. And therefore, the counseling and the information provided to women who choose or are using NET10 should be the same as that for DMPA IM. So over to you again.
Great, thank you, James. Sorry, I was now on mute. Really appreciate that. A number of additional questions came in, and let me ask one, and then maybe we'll go to open the line. A question, and I know it's been discussed certainly by a number of us in civil society in partnership with you. The role of PrEP potentially for women at high risk of HIV who may be made aware of this new mech but still want to use DMPA. Is there a role for PrEP to be offered in a more strategic way in the context of contraceptive provision? I wonder if that was discussed with implementers at all, or how that might play out.
So there have been quite a number of discussions on the role of PrEP. The PrEP, I think, should not be seen as the intervention to address any increased risk from if there is possible increased risk of HIV acquisition due to DMPA, then we should really look at the options at what the options and the counseling and use of condoms and so on. We should not look that maybe PrEP will have a role in terms of all the women that are using DMPA. However, I think that it's very important that we really think about rolling out PrEP in the context of family planning. And for these women who are coming to family planning clinics or using family planning, in some of the contexts, the women are at a very high risk of HIV infection, irregardless of whether they use DMPA or not. And therefore, for me, and we have had some discussion with our HIV colleagues and also with those implementing PrEP programs is that we know that several family planning programs are seeing very high-risk women. And these women should be able to access PrEP for HIV prevention, not because they are using DMPA, but because they are at a very high risk of HIV infection. So I don't know, Michelle, whether that addresses the question.
You're very, very helpful, James. Thank you so much. Let me pause. Other questions have come in, but let me pause to see if anyone on the line would like to pose a question. And I know a few people actually on the line were with you in Johannesburg at the recent set of meetings and would love to hear from them as well. So let me just pause now, and if people want to hit *7 to unmute your line, introduce yourself, and then we will go from there.
Mitchell, can you hear me?
Yes, I think that's Anna. Go ahead, Anna.
Yeah, hi, this is Anna Forbes. I was one of the advocates attending the Johannesburg meeting, and what I heard very clearly from participants was that one of the biggest obstacles to getting this information out was underfunding of family planning units, that they simply didn't have enough staff and enough time to do the kind of counseling with women that is required to really convey all of the ins and outs of this issue. One provider said they were so understaffed that every client was getting about 3 minutes or less of counseling, and it's certainly not possible to explain the upsides and downsides of Depo-Provera and PrEP and so forth in that amount of time. I wondered if there is anything that WHO is doing or can do to join with advocates in calling for increased funding for family planning units so that they can staff up in order to meet this challenge realistically.
So thank you very much for that question, and that is completely correct, that underfunding and lack of counselors and problems really with the resources available is a very big obstacle to getting this information out and to giving opportunity for women to receive full counseling. So in WHO, we've been doing a lot of advocacy for increased funding for family planning. And actually for us in HRP, our Scientific Technical Advisory Group recently published in the Tribune, and maybe I can send to Michelle to share that article, an article that is addressing this issue of underfunding for sexual reproductive health services, because it's not only family planning, but the SRHR agenda is very seriously underfunded. So we are also calling for increased funding in this area, and as you know that there has been very serious problems of funding, both for the personnel required and even sometimes for the commodities. So thank you, and also thank you for highlighting that.
Thank you.
Great. Sorry, I was actually back on mute. Just to pause again for any other additional questions or comments on the line. Again, *7. All right. There were a couple of notes I got asking for additional information about the issue of cyanopress, and I know you covered that earlier, but some questions of confusion, and I think people do want, and I think as you described the meeting in Johannesburg, really wanting to be clear that we're communicating accurately. And And just to, again, one of the questions came in from a wonderful activist working extensively in different parts of Africa about the counseling needs related to Depo, NetN, and Cyanopress. And just wanted, she was asking for clarification if the counseling, if you're suggesting the counseling needs to be the same across those three different methods, DMPA, NetN, and Cyanopress, or if that was a misunderstanding, and just to be clear.
Okay, yes, thank you. So the recommendation is that in terms of risk of HIV acquisition, counseling for DMPA subcutaneous, DMPA IM, and NetN should be the same. And at the Johannesburg meeting, we presented a draft of what we are thinking around these, the key components of what that message needs to be. And the key, and although this is still in draft, is not the WHO recommendation yet, the three key issues is: one, women should be made aware of these concerns, so that women choosing DMPA, NetN, and DMPA sub-Q should be made aware that there are concerns that these methods may increase HIV infection risk, although it is not known whether they are the cause, but there is some concern. So that is one key kind of outcome that should be there for the counseling process. The other key outcome is that the women should be aware that they can take steps to protect themselves from HIV infection. Use of condoms, that they can have testing together with their partners and be faithful to an infected partner, that they can use PrEP, and all the options for HIV infection prevention that may be available. That should be another key message. The other message is that to just reiterate that this is a shared decision, and the method that they opt to use is this particular method, so that they are making an informed choice. So those, and that is what we are working, when we hope maybe in the next few months, we will launch the handbook, and it will contain those messages. So the counseling should be the same for the three methods, because from the review by the expert panel, and they did go into this issue in depth, they did not see any reason to have different recommendations for the three methods. Thank you.
Great, James. Thank you so much. And related to all of that, a question came in. You mentioned that some of these drafts were made available for discussion at the Johannesburg meeting. A number of people have already emailed or posted. Will there be opportunity for additional review? And if people are interested, both implementing partners and civil society advocates, if they are interested, can they get in contact with you, or is there going to be a formal process by which people can feed into those materials?
Yes, so once the materials have been, because these were very early drafts that were shared, we did get some input, and I'm sure in the meeting it was said that if people have comments on the materials, they can send comments. But once they are closer, then they will be shared widely for people to comment. So there will be opportunity to comment on them before they come out in the handbook.
Great. Thank you so much, James. One other question came in, and you mentioned earlier the importance of linking not just implementers with the evidence and with advocates, but also the basic biology and basic science. And someone asked a question related to that, saying that as far as they can tell, the guidance statement talked about reviewing only data up until 2013 about biologic plausibility, but noting that between 2013 and the end of last year, that at least 10 additional studies have been published related to biologic plausibility, and wondered if the group in December actually reviewed the most recent biologic evidence or only the evidence through 2013.
That may be my mistake. The evidence, the expert review group reviewed up to the latest published biologic mechanisms that we had. So they reviewed up to the most recent that was available.
Great. And again, we will be posting the slides and which include, of course, your Twitter and WHO handle. I know people can get in touch with you directly if they have additional questions. Let me pause. I know we're just about the top of the hour, but let me just pause to see if anyone has additional questions before we wrap up. Any last thoughts? Again, star 7 to unmute yourself. All right. I do want to, again, thank you, James, for a very in-depth and important presentation and information that continues to evolve, really, as conversations continue. I think additional questions about not just what the evidence shows or implies, but importantly, coming out of the Johannesburg meeting, how this gets communicated with implementers, with advocates, and most importantly, with women who are making really important choices and should be having all the options for both their contraceptive needs and for their HIV prevention needs. I really want to thank you. I also want to thank Anna, who you heard. A number of other advocates were with her in Johannesburg at those meetings, and grateful for that, and really happy that WHO opened up that meeting for additional advocate voices, and also gave an opportunity for us to have a smaller civil society meeting in advance of that series of meetings to engage. And those are ongoing pieces of work. And want to make a particular thanks and shout out to Lilian Moreto and Margaret Happy from ICW East Africa and Emily Bass from AVAC, working with a number of you and working with WHO to make sure that these decisions are not just based in meeting rooms and analysis of data, but rather are informed, most importantly, by voices from those communities. And just want to really thank Lilian, Margaret, and Emily for being the leaders in this effort. And apologies that because of technology and other meetings that they were not able to see the voices, and you got stuck with me. But want to thank you all. James, thank you again. This, as I said at the very outset, this is not the first call we've had on this topic, and as you can undoubtedly know from the way we're ending, this will not be the last call on this topic. If you have additional questions, if you need to get in touch with James directly, and we have certainly found James to be a remarkable partner and conduit of information, so I know that people who want to get in touch can ask additional questions of him. And we look forward to working with all of you and making sure that this information is applied in an evidence-based, a rights-based way across the countries and communities where these issues of both family planning and of HIV prevention really are so very important. Thank you again all, and we look forward to many more opportunities. And James, thank you again very, very much.
Thank you. Bye-bye.
And cheers all. Thanks again.